And now to introduce our speakers. So both Dr. Steve Ferrucci and Mo Rafatieri are good friends of mine, and I know too much about them and their accomplishments, which makes it difficult to create an abbreviated introduction. So I actually asked them for help as to what I could say. And so I'm just going to briefly read you what they both sent to me for how they wanted to be introduced. So Mo has been at the Charles Retina Institute for 25 years, where he serves as a retina consultant for colleagues and is a past president of the Optometric Retina Society, chair of the American Academy of Optometry Retina STIG, and according to Mo, Steve's only friend. Steve has been at the Sepulveda VA in Los Angeles for about the same period of time, has also served as the Optometric Retina Society president, and along with Mo, co-chairs the ORS Retina Update meeting. And further, Steve said he's just here tonight to assist Mo. So with that in mind, I'd like to welcome my two good friends to help educate us, and I can't hear what they have to say.
Thank you, Jeff. Thank you all very much, the sponsors. I guess I'll go ahead and share my screen. So I will be running the slides so I can control Steve a little bit tonight. So the topic of tonight, and thank you all for being here. I noticed that we have about 700 people or so far registered. So this is amazing, you know, how you can reach out people with this technology. So AMD and AMD Imposters. This is our disclosures. Both Steve and I are on ad boards and speakers for a number of sort of industries, both pharma and imaging industries, but this talk has no bias, commercial bias. So no further ado, age-related macular degeneration is a specific condition. You know, there are many macular degenerative disorders, but not all of them are age-related macular degeneration. And what are, either the non-neovascular, just the atrophic nature of the disease, and neovascular disease, a lot of people lose eyesight to this condition. You agree, Steve, that this is a specific disease, and, you know, like I always say, if my uncle has a mustache, not everybody with mustache is my uncle. Not every macular degenerative disease is age-related macular degeneration. Just chime in, you know.
Yeah, no, I never know what you mean by that mustache comment, but I agree with you on, AMD, that, it's very common, but there are things that look like it, and there are important reasons to differentiate AMD from AMD imposters, and hopefully that's what we'll get to tonight.
And part of the problem is both in incidence rate and what we have to be keeping under our radar is, by all accounts, AMD is on a rise because we have an aging population. So no matter what resources you look, they forecast an increased number of patients. So we all, no matter what type of practices we are, we come in contact with these patients, and we have to deal with them. Whether you are in a retina practice like me, or the VA like Stevie's, or private practices of all sorts, industry practices, all of that, practitioners come across this disease. And we know there is a multifactorial condition, both genetic susceptibility, environmental factors, things like smoking, dietary habits, systemic disorders, or what have you. These all play a role, so we do a risk assessment pretty much to diagnose this. So ethnicity, we all know Caucasians have a higher chance, than other ethnic groups per se in the country. There is genetics of macular degeneration, and it's very complicated. Do you want to say something about genetics of macular degeneration, Steve?
Yeah, I think the genetic, I think we're just at the tip of the iceberg when we start to think about the genetic factors of AMD. And there's, a couple companies now that are doing genetic testing that can help us, prognosticate the patients that may get worse and those that might not get worse. And then we can follow different patients individually based on their individual chance for progression. And there's also some treatments, and we're not going to talk about treatment tonight. We'd love to do that with you guys another night, but We're not going to talk about treatment, but they're actually also starting to look at some genetic treatments for macular degeneration, which I think is absolutely fascinating. So I think we're just at the tip of the iceberg when it comes to genetics. And I think in the next several years, we're going to learn a lot more.
Yeah, and our makeup, whether it's genetics or just structural or, low macular pigment, tobacco use, tobacco and aging are the most commonly discussed risk factors on AMD. And I'm gonna nip it here because every time I give a talk about tobacco use and smoking, then the questions come, what about vaping? What about chewing? What about this? What about marijuana? We don't know about marijuana, so I'm not gonna get in there. But all forms of nicotine, including nicotine gum, is not good. There is adverse reaction. Now, although with smoking you have, to nicotine you have added the carbon monoxide and carbon dioxide and the lung capacity issues and ischemic issues and all that. But nicotine in all forms is detrimental to human tissue. So, and of course, lifestyle, especially our eating habits. And, to me, they always talk about Mediterranean diet being good for AMD. To me, I don't know what your opinion is. It's hard to get a 65-year-old to change. And to some degree, if you ate like that, the Western diet for 65 years, I don't think switching to, Mediterranean diet, although they say it's never too late, is not as good as having a cultural change to start the better dietary habits at a younger age. So
Yeah, I think you're exactly right. It's hard to tell a patient who's eaten one way their whole life to change the way they eat, but it still should be discussed. And as far as smoking goes, there's a study that said that something like 60% or something of patients with AMD, it might even have been more, I'm forgetting now, said that no one told them that smoking is bad for AMD. So I think it behooves us as healthcare professionals when we see patients with AMD or we know a patient who smokes. I think it's worth just spending 30 seconds explaining to them the dangers of smoking.
And that's true because a lot of patients I see, referred to me that you can smell it in the room when you say, did anybody ever tell you to quit smoking? And they're surprised that it's not the cardiologist tell them not to smoke. The one other point too is to realize, because sometimes when I talk to colleagues who are in metropolitan areas, they see a decline in smoking. But if you have rural practices, according to the CDC, people in rural areas smoke 15 cigarettes a day more than people who live in metropolitan areas. Do you see a decline in the VA patient population in smoking?
I think that I do. I think that I see less patients smoking now. The older patients, like I don't have a lot of them, but the World War II guys, they all smoke, right? But they're dying off. And I think the younger people aren't smoking as much. At least that's what I think I see. But I'm not, I've never really done a study, but that's what I think I see.
So this study, and most of us know about this study. The interesting fact about that is how many patients were missed that had AMD by both general ophthalmologists and optometrists. And when they did photograph, analysis of those patients, a large number of them had AMD, and a good number of them actually had intermediate AMD. These are patients who are at risk to develop either geographic atrophy or choroidal neovascular membrane, neovascular AMD, So this disease is easily missed, and I can see why. Sometimes it is really difficult at the slit lamp with the 90 diopter, with a patient who's got 3+ NS and, moving their eyes. And especially these days with the mask, and your 90 diopter is fogging up and you're fogging up the other end of the slit lamp. So I can see how easily that can be missed at the slit lamp, if you're not paying close attention. So it's staggering, and we have to be more careful. On the other hand, I have seen many patients over the years that don't have AMD, which is primarily what we want to talk about tonight, although we have to talk about some of the characteristics of AMD to see, okay, what is an AMD? Like this example I have here on the screen, a 35-year-old female who's been diagnosed with AMD, and this doesn't look like AMD. I may not know what it is, but I know it's not AMD. Part of the difficulty of that is there's several macular diseases. Many of them share genotypic, phenotypic similarities. Many of these with time change, and as time changes the tissue, doesn't matter what causes fire to a building. At the end of it, you got damaged building by fire, whether it's somebody fell asleep with a cigarette in their hand or the electric fire or what have you, the damage looks the same. So it makes it difficult, this morphologic changes. Do you see in your patient population patients who've been told to have AMD and you don't think they don't?
Yeah, certainly. You see these patients that come in and they say they went to another doctor and was told they have AMD, and you look and you look and you look and you just can't quite figure out why they were told that. And one would argue, sometimes if someone says you have early AMD and they don't, does it really matter? I mean, I think it is important to make the right diagnosis. And when you start thinking about treatment and how you're going to follow that patient, whether you're not going to institute vitamins and stuff like that, I think it does make a difference. So, I think it is important to try to rule out some of these mimickers and make sure that you truly have macular degeneration. And, one of the most important things to me is, you have to look at the patient, right? You have to look at the demographics. I mean, a 39-year-old patient, right, is more than likely not going to get AMD, right? It's going to be something else.
Or if they have AMD, it doesn't show up clinically yet. I mean, they may be a pre-AMD patient, but you don't see a retina like this in a 39-year-old.
Yeah.
To me, making that distinction, one is some people or many people have heard that my aunt had AMD and macular degeneration, and she went blind from it. This fear of what's my chances. The flip side is people who have, let's say, adult onset vitelliform degeneration. That's that's an autosomal dominant disease. So if a patient has it, their progeny has a much higher chance to have that condition than somebody who's got AMD. So sorting through it, and it's got a totally different clinical course. So it's not just academic. So the better diagnosis we have, the better management. And there are a whole bunch of masquerades. Some are macular degenerative and dystrophic diseases, and some of these, effects of other conditions. Even white dot syndromes can damage the macula, and at the end of the disease, somebody's got mutes or PIC or, this type of conditions. One thing we have to realize is, doesn't matter what causes damage to the retinal pigment epithelium and Bruch's membrane, you develop risk of neovascularization. So which also creates a difficulty, because a lot of these patients show up with the choroidal neovascular membrane, and the immediate reaction is, you got AMD, you got wet AMD,
Yeah, I think that's a good point, Mo. Like when we think about CMVM, we almost always associated with AMD, macular degeneration. And certainly that's the most common cause of CMVM, but there's other things like myopic degeneration is probably the second most common cause of a CMVM, histo, angioid streaks, trauma, idiopathic. So there are a lot of other reasons to get choroidal neovascular membrane. It's not pathognomonic for macular degeneration.
And also the difficulty in that is not, the medications that get FDA approved for choroidal neovascular membrane is first AMD, and then the next they go for a myopic macular degeneration, because as you said, that's the second most common. So if somebody's got some other diagnosis, sometimes diagnosis is fudged so the patient can get treated with other than, Avastin, but, so it pigeonholes, So when we go to diagnose somebody with AMD, what are some of the things we use? First, if somebody's got preclinical disease, because we don't always have the luxury to see the patient from the earliest to late. People jump from stage to stage, but this diseases change from an early. What do we do? Do we go based on the patient's, history and symptoms? This could be a patient who's got AMD, who's got some vision distortion and changes, but they don't catch on to it that easy. So you can't just rely on the patient, and functional vision and Snellen chart vision are two different things, so you can't always rely on the patient coming and telling you their absolute true, symptoms. And based on that, you say, okay, you got AMD or some other condition, So risk assessment, like we talked about, as Steve just mentioned that, what are the demographics of the patient, the age, ethnicity, family history, and then we go based on a whole host of examination. And I'll put all of this up, so we got a whole host of functional tests like this. To me, I don't know how you feel. Snellen acuity is a good test if you're, managing, healthy to diopter myopes, and you put this chart and you focus their vision. But when you're dealing with macular degenerative disease, I have patients who have horrible GA and they're still 20/25. I had a patient today that I brought in to screen for one of the clinical trials, and she has a choroidal neovascular membrane, and she failed the screening for the clinical trial because her vision was 20/25. And she got treated for a choroidal neovascular membrane today. So
yeah, no, you're right. I mean, Snellen acuity is great. It can give you an idea of what's going on, but we've all seen patients with significant disease that have good vision, and patients that have bad vision and have no clinically significant disease. So it's a good starting point, but it is what it is. But one thing that I like this slide, Mo, because it kind of shows that there's different ways and different things we should be doing to look for our patients with AMD and that sort of thing. Because if you think about it, if we have a patient with glaucoma, right, which is less prevalent actually than macular degeneration, we often do a lot of testing on that patient. We're going to check their visual field. We're going to check their corneal thickness. We're going to check their visual field. I think I already said that. We're going to check their IOP. We do a bunch of different stuff. But with AMD, up until lately, you just look in their eye and you just say yes, they have it, or no, they don't. So I think that these other types of tests, whether it's dark adaptation or home monitoring, different things we can use to take better care of our patients with AMD, both to help diagnose it and follow it.
Genetics you already talked about, so I'm going to go past on to you, but this is also the future of diagnosis. And to me, you talked about the AMD diagnosis, but in Mendelian disease, that's the inherited retinal degenerative disease, is also important to test them for those. So to figure out, this is, if it's not AMD, then what is it? Which one of the, gene predispositions these patients have, So you can find a whole, I had a young patient, for instance, that had a very weird macula, and genetic testing showed that he has North Carolina dystrophy. I would have never diagnosed that at looking at this, the macular finding. It was an adopted child, so it's very helpful. Genetic, testing is going to be in our future as to better and better diagnose patients. And then the beauty of it is a lot of the stuff, you talked about just not the functional, that you like to do functional testing, but the beauty of it also is the eye reveals itself. A lot of these diagnoses are based on structural finding, and we have wonderful, technology in imaging and structural diseases. What's your favorite in testing? Is it OCT, fundus photography? Do you have a favorite?
Yeah, I mean, I like OCT. I think OCT is, great for looking for drusen and making sure there's no fluid, especially if a patient presents with metamorphopsia. And then, we have an OCT angiography, which I think is very helpful, to actually visualize choroidal neovascular membranes, which might help, with treatment. Fundus photos are a nice adjunct as well, but I really think the OCT, is probably one of the best ways to look for any, early signs of fluid.
I know I like fundus autofluorescence.
Yeah.
You're never gonna buy that, but I like fundus autofluorescence.
I think it's nice in certain circumstances to, help maybe differentiate AMD from some of the mimickers, which I'm sure we'll have a couple cases later that shows that nicely. But other than that, I don't know. I'm not a huge fan. I've never done a fundus autofluorescence that I've been, now I know 100% what's going on. Maybe it's just me, but I'm not as impressed with it as I know you are.
There is a little predictive ability with patients who have GA and things like that too. I may have a couple of them in the slides,
Yeah,
So this is a very busy slide, but this basically is a cascade of what happens in patients with macular degeneration. The retinal pigment epithelium is perhaps one of the most biologically active tissues in the human body. And that's its own demise. It burns up a lot of oxygen, choroid by far has the most amount of blood flowing into it. And the main function of that is actually as a coolant, to cool off the photoreceptors. This tissue is, unless you sleep, is constantly exposed to toxic light, whether it's blue light or visible light or invisible light. It's being bombarded by bombs, and that's how it functions. So then, and then we add, added oxidative stress to it by, again, smoking, not eating well. So this junk piles up, causes inflammation. If you have the complement, the inability to fight off this inflammation through your complement cascade, then, is a vicious cycle. Then you have, we remember, Steve, the apoptosis sort of theory that sort of faded away, the pre-programmed cell death, but that's true. I mean, some of these cells are not to hang around for 90 years. And we have patients who are 95 years old, 105 years old, 89 years old. So the cells just die off. And as a result, you get either damage to the RPE, or then the function of the RPE cannot eliminate choroidal neovascular formation. So you get choroidal neovascular formation. So this is the cascade of a disease. And like I said earlier, we don't always have the luxury of seeing these patients from before to after. They can jump to the clinic. You could see a patient and then 10 years later, they come back, they look different. There's all sorts of looks and shapes to this condition. So now to go through some of the findings with AMD, to me, to diagnose somebody with AMD is supposed to, and do you see my mouse, by the way, when I move it around? You do? Okay. So to me, AMD is a diffuse disease. So the first thing to look for is to see how this whole area is called the macula. I was given a Zoom talk the other day, and one of the audience asked, how close does the drusen have to be to fovea for you to diagnose AMD? Well, if AMD was a foveal disease, it would cause age-related foveal degeneration, not macular degeneration. So when this disease starts showing clinically, doesn't matter what you can see, and on fundus autofluorescence, drusen actually hypoautofluoresces. So this image you can see much better in either in fundus autofluorescence, or if you have a certain instrument that does a good IR photo, you can see that on the IR photo also. But that's the same patient. If I look at them clinically, I just see a few drusen here and there. I miss this diffuse disease, So this is one place where I can look at somebody and say, yes, Miss Jones, you do have macular degeneration based on this, And the other aspects of it is the choroid of a patient who's got AMD is thinner than normal. So in myopic macular degeneration, you see this too. Whereas in central serous, what do we see, Steve?
Central serous is generally quite a bit thicker.
Thicker choroid.
Yeah, quite a bit thicker.
So those become diagnostic tools that we use, to look at. Look at the IR photo of this patient I was talking about. You can see this leopard look as compared to a normal IR photo where you don't see this leopard or mottled, format. You can see this very robust choroid, robust RP, as opposed to the drusen, which is the extracellular from the RP, is the biologic byproduct coming from the photoreceptors. RP is supposed to recycle those, but it sits there and it builds up. Any comments about these before I move?
No, I think you bring up a good point. I'm not a huge fan of fundus autofluorescence. I'll let you convince me otherwise. But I do like red-free, and I do like infrared, in a lot of things, whether it's AMD or diabetes, because sometimes you see little hemorrhages or little somethings that you don't see in color. So, if you're taking a regular fundus camera, I think it's worth the extra couple seconds to switch it over to a red-free filter, because you do see stuff differently.
And then you go back and then do clinical correlation to your color. Yeah. Because on either fundus autofluorescence or on red-free or IR, microaneurysm or a hemorrhage is going to be a darker spot. Then you have to go back and say, is that yellow, red, brown, what color is it, to give the clinical diagnosis. Yeah. Now, this patient here with the earlier sign of age-related macular degeneration, this is that patient's fellow eye. So choroidal neovascular membrane, although the chance of formation goes up as the disease, as the dry disease progresses, but it could happen at any time. Even if you look at this eye, it doesn't really have bad, large drusen or what have you, but the patient has developed a choroidal neovascular membrane. So when I see those findings in the patient with their choroid and with the FAF, and I have this fellow eye, then I don't need genetics. I don't need, the diagnosis is met. This patient has AMD. No ifs or buts or what have you. In areas where you can do angiography, drusen sort of hyperfluorescence by staining. Steve shares a commonality with me. He has a Tennessee license. Why do you have your Tennessee license?
So I can do fluorescence. That's
That's the beauty of the VA hospital. So
Right.
it allows you to practice at your highest scope.
But it is true though. Sometimes when you do fluorescence, you do see quite a bit more drusen than you do on clinical exam. That's not to mean I would
No, I wouldn't do it, but
in all patients, but sometimes you do see a lot more. So you should
and then
wait up.
with OCTA we do less. With OCT and OCTA we do less and less of it. In OCTA, dry AMD doesn't show up.
Right.
Choroidal neovascular membrane shows up.
True story.
Right. And then the disease progresses as the drusen gets larger. And I have this way, and Steve has his own way. If I don't see drusen, if it's hard to see, it's small drusen. If I can see it easily, is intermediate. If it slaps me in the face, is large drusen. So that's how I classify it. I think you have your own way of classifying it.
Yeah, I mean, no one measures, right? I mean, if you look at the studies, you have to measure the size. No one has time to do that. So, I just kind of, eyeball it after seeing this a lot of times. You have your own way of figuring it out. And I think what you said is actually kind of interesting.
So on FAF, if you start seeing hyperautofluorescence, that's actually lipofuscin. So that's the intracellular material from the RPE metabolism itself. And if you start seeing lipofuscin, that means you really got a sick RPE now. And those areas are the areas that are at risk to either develop, geographic atrophy or go on becoming choroidal neovascular membrane. So that's the sickness of the retinal pigment epithelium. So this is an example of an OCTA in a patient who's got lipofuscin. So I'm worried, is this a choroidal neovascular membrane? And that's a good time to do it to make sure there are no vascularity in the avascular zone, with the caveat that if you have a lot of material here, it can actually mask a little neovascular membrane. So you have to worry about that. And then as you can see, this is a progression of a patient from one year to the other. The dates are, hidden behind our cameras. I can't see them. But lipofuscin, drusen, all of this material eventually gets metabolized. It can go on. And like I said, as it goes on, then you can discover the loss of tissue, which is geographic atrophy. Then you can these pigmentary abnormalities and things like that nature. So we all have seen this progression come about. Do you make any points about it?
I mentioned I don't like fundus autofluorescence in some cases, but I do think and the studies are starting to show us that it might be helpful in patients with geographic atrophy. And the theory is that if we have a lesion and we see like around a geographic atrophy lesion, a lot of it, lighting up, hyperfluorescence rather, that means that that's probably an active lesion that is still actively growing, versus if it's nice and dark, that's probably not an active lesion. So, I bagged on fundus autofluorescence, but I do think it has its place.
No, and Jeff Gerson always says, when you look at that, the dark area is the forest that's burnt, and the light area is the forest that's burning. And that's the way you can think about it. And that's true. But if you look at this patient again, these areas where you got this sort of like mottled hyperfluorescence, over time, all of that became geographic atrophy. So if you are in an area where, you have a established set of patients, then unlike what I said, you do have the luxury of seeing some of these patients year and year. The sad part is you see this dying tissue and there's still nothing we can do. Bear in mind, when patients are injected with anti-VEGF for a choroidal neovascular membrane, they're not being treated for age-related macular degeneration or histoplasmosis or myopathic degeneration. They're treated for their choroidal neovascular membrane. that disease now is called neovascular AMD or NAMD. So the indications for NAMD, but not for AMD itself. And like I was saying earlier, this is a patient who can no longer drive, but still has 20/25 vision. Has a hard time reading. Why? Because they have, persistent photoreceptors in the fovea and the RP, but the rest of it is wiped out, so they have no saccades. These are dangerous people when they say, I see to drive. I'm like, you see what you see, but you don't know what you're missing. A little boy on a bicycle goes missing, comes back missing, so accidents happen. These are good patients for low vision evaluation.
Yeah, and those are the patients with GA like that. I find particularly hard because there's really nothing you can do to prevent it, at least at this point, prevent it from getting worse, and it's just very frustrating for the patient as well as us, I think.
So there are studies now, to deal with, and that they are, our senior doctor Steve Charles is going to Bethesda this week to do the first human subject as to transplantation of RP and photoreceptors.
Cool.
So yeah, so we'll see how that pans out. My concern with those patients, I've had this conversation, when that tissue dies, choroid becomes dysfunctional a little bit. So the sort of oxygen support and food support is not there. This is a nice chart. So if these things we showed, large drusen, hyperpigmentation, if you see these, like somebody's got large drusen pigmentary change in one eye, and each one of those gets a point. So somebody with 4 points has 50% chance of going from dry to wet AMD in 5 years, whereas somebody that has none of these doesn't have much of a chance, but it does have a chance, like I showed you earlier. So this is a good sort of cheat sheet. So if you're seeing this, and what that's a drive to is to how often do you want to see the patients, and if these patients are having intermediate AMD, is a fantastic idea if you can prescribe the home monitoring devices for them, because then you don't have to worry about them as much. And this is a nice chart that my colleague, Dr. Jessica Haynes, colleague of mine at our clinic, did for to lay out the progression of the disease and how you can follow it or what have you. And this is in your handout. So, and then the next step would be neovascular AMD. Now, none of these show up as this classic hemorrhagic. Sometimes the patient who shows up really nice, looks like dry AMD, and the FA doesn't really leak much, but on OCT they have leakage of fluid. They have this, fibrovascular PEDs, and this patient responded to anti-VEGF. So I know this was not a, far-fetched. The flip side is you see a patient like that doesn't have all those qualities you look like, and then you do OCTA, and sure enough, this patient has a neovascular AMD. So
yeah, I think you make a good point that there's all types of patients. Some you don't think they leak and they leak. Some you think they leak and they don't leak. And that's why multimodal stuff in OCT and OCT angiography, they all give you slightly different information. But to me, one of the most important things is anytime I have a patient with AMD, if they come in complaining of metamorphopsia or they have a change in vision, in my mind, they have wet disease until you can prove otherwise. And that's the big rule out. And we know from multiple studies, the sooner we treat wet macular degeneration patients, the better their visual outcome is going to be. So anything we can do to diagnose them earlier is better. And by using OCT, if a patient says, gee, I think I have a change in my vision, you need to look and make sure there's no fluid. If you don't have an OCT available to you for whatever reason, you have to refer those patients out.
Excellent point. And then we're not going to talk about management tonight, but again, just there's no treatment for dry AMD. Make sure you follow the rules of, dry AMD management. And when these patients develop wet AMD, they end up in what I call the anti-VEGF black hole. They become, because of chronic disease, and most of these patients need long-term treatment, Yeah. So now the AMD imposters, there are a whole bunch of them, and we have a few cases, few examples here to run, and again, to distinguish some of these, some of these characteristics. So here I have a case, it's an interesting case, and it's a made up case. So I have to make that disclaimer, So imagine this is a 60-year-old that comes to your office as a new patient. you know, Caucasian female, and has some complaints. It's getting hard to read, you know. I'm having a hard time seeing at night, you know. They have one, you know, trace nuclear sclerosis, and you look at them and they have a little bit of, you know, pigment mottling, and this is important. This point is important. Is nasal to the fovea. The location is nasal to the fovea, and we'll talk about why it's important that's not temporal to the fovea in both eyes. And then even on your IR photo, you can see this pigment mottling. You can see this damage to the, some of it to the, you know, the so-called ellipsoid zone, and some of it is the RP is not, you know. So Steve, do you imagine somebody looking at this patient and say, ma'am, you got macular degeneration? Is it?
Yeah, I mean, I could see that. I could see that happening. I don't think it is macular degeneration.
No.
It's some sort of macular something, but I don't think it's macular degeneration.
No. So some macular degenerative disease.
Right, but I could see someone. I mean, you know, 60 years old, complaints and whatever. I could see someone saying, "Oh, you have early macular degeneration." So I could see someone making that misdiagnosis for sure.
Well, this is a macular disease basically, and you wonder like, okay, what doc? I've heard about vitamins. What about vitamins in you know so far? My aunt went blind. Now this is a 20-year-old. This is a 20-year-old who's in the second trimester of pregnancy, and she has preeclampsia. Used to be called toxemia pregnancy. She's got a hemorrhagic, you know, retinopathy. Basically, is a stage 4 hypertensive retinopathy. And I'm seeing this patient after she was diagnosed with the preeclampsia and has lost some vision. And that's why she was sent to my clinic. And I look at this patient, I'm like, well, are they getting your blood pressure under control? Yes, that's all you need to do. There's nothing else. We just watch you to make sure what happens. And as this disease clearing up, you can see those pigmentary changes showing up. So this, imagine this as a scenario of a patient. Do you honestly believe a 20-year-old that went through this is 60-year-olds? No, that child is a 40-year-old boy or a man or a woman who's probably, you know, gotten married and divorced, and the lady probably is having a hard time paying her mortgage and all these different things. Do you think she's going to offer to you as a new doctor, eye doctor to her that, hey, by the way, when I was in my 20s, I had my, you know, first of 7 children, I had preeclampsia? No, I mean, these are some of the challenges, you know. So invariably, if I see pigmentation in particularly a female patient that looks odd, is one of the questions I ask. Do you have any children? They look at me funny. Yes, no. Did you have any problem with your blood pressure while you were pregnant? Or if it's a guy, have you ever had any problem with your blood pressure? You know, and it's not unique to this patient. I mean, any kind of macular flooding disease, whether it's diabetes or, you know, this one, this lady had severe anemia, and this sort of like is a choroidopathy per se. And once it cleared up, you can see that the other retina is damaged. You know, a lot of our diabetics with bad macular edema, once we get rid of it, is not just the inner retinal ischemic disease, but is an other retina photoreceptors, and, you know, RP gets damaged. So we have to put those in perspective, you know, and not just jump and diagnose people with macular degeneration. Any comments about that? I'm sure you've seen plenty of this in your clinic.
Sure, yeah, and you're exactly right, though. I mean, you know, you have to sometimes play detective, and, you know, these patients don't link X to Y to Z. So, you know, sometimes you have to go way, way back. You know, I have a patient with a central serous that kind of looks like an AMD, and you really have to start quizzing them. When did this first happen? And da 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 da. So you really do sometimes have to go back quite a bit to figure out the whole story for sure.
So this one is a patient who's referred to rule out wet AMD. Is a 67-year-old white male, you know, is having a hard time reading. He has had phaco 4 or 5 years ago, and he wasn't seen again until last year. And he thinks his prescription, everybody thinks everything relates to their prescription. I use prescription glasses, you know, my analogy to that is shoes. If your foot is swollen, it's not the fault of your shoes, you can't walk, you know, your foot is swollen. So if you can't see, it's not all, because that complaint exists. My doctor gave me a wrong prescription, I can't see it. Their maculas are chewed up by something, you know, that's the reason you don't see, you know. 2020, 2025, And these are the findings of this patient. So it's got this like listening material, this mottled look to, but most of the disease in this patient is temporal to the fovea. This is a distinguishing factor to this specific condition. And it's interesting, if you're diabetic in this condition, you're usually diagnosed with diabetic retinopathy. And if you're old with this condition, you're usually diagnosed as AMD, and I've seen that a number of times. What is this condition? These are the other testing of this patient, so they got a leaky macula. It's sort of like CME, not the leakage you see from AMD neovascular membrane. The fundus autofluorescent, again, to point out, you don't have diffuse disease, you have these localized areas of damage near the fovea. So that's one of the first things I look. Is this disease, again, generalized to the macula, or is it just localized to some area or what have you? So this is MACTEL, macular telangiectasia, which is a neurodegenerative disease, basically. You can imagine this is sort of like MS of the retina. And before OCT, we really didn't understand this disease as well. I remember pre-OCT, we used to inject these patients with steroids, and we had angiograms on them, and in angiography, their fluid level would go down, but their vision never got better. And we never understood until OCT showed that they have other retinal disease, and getting rid of that fluid doesn't get rid of the other retinal disease, and that's why their vision didn't get.
Yeah, I remember, when we first got OCT, we started to see these patients, and I'd see one with this, especially MACTEL2, which is the most common form, and I'd be like, oh, this is a rare thing. I'm never going to see it again. And it's really a little more common than one would think. And it's sometimes in the younger patients, very often associated with, like you say, diabetes. Patients with diabetes probably have it a little bit more, and they're more likely to leak. But it's relatively common. And this is one thing that I do see a lot of people misdiagnosing as AMD.
And it's interesting, once you see one or two of these cases, then it's sort of like, again, as a stupid analogy, sometimes somebody asks me, how do you know that's that? I say, that's the same way I know a pigeon is a pigeon and a pelican is a pelican. When you were a kid, they told you that bird is a pigeon, this bird is a pelican. So it doesn't take long for us to pay attention to these things. And sometimes we may jump to conclusions too fast, but it becomes inherent to us, and like you said, type 2 is the most common. There is a type 1. The type 1 is unilateral, is more like Coates disease, like a developmental, where type 2 is most likely genetic. There is no treatment for it. There are some studies. We are involved with the MACTEL2 study with ciliary neurotrophic agents, and we can't still find the correct subject yet. We submitted a bunch of patients, and they rejected every one of them. And then type 3 is this non-exudative. The type 1 usually has more of a diabetic look to it than an AMD look, but type 2 is the most common. Again, as to one of our problems is these diseases do progress, and you never know when are you going to see this patient. Is it when it's hard to diagnose with a couple of these glistening stuff, or once the hyperpigmentation show up, So, and that's part of the leading to misdiagnosis. So it does change. It goes through a variety of changes, and these patients do have chance of developing choroidal neovascular membrane. And when they do respond to anti-VEGF, just like any other choroidal neovascular.
Yeah, exactly right. And anytime you see that little pigment spot just temporal to the macula, to me, it's a very good sign that this patient might have MACTEL, and then you want to look for the associated blood vessels. And once you see that a couple of times, then you know it's a pigeon or a pelican, whatever.
There you go. Yeah. You like that, didn't you?
Yes, I do.
And most of these patients do well, except like sometimes this was actually a, very young female that worked for one of our local optometrists, and she finally had to file disability because she lost so much vision due to MACTEL. So sometimes it does become, tragic, but most patients do well. Is this AMD? Somebody with, again, a 56-year-old African-American female, I see that says, ever since I was 30 years old, I was told that I have macular degeneration. Robust choroid, all this bruising all over the place. So I look at this and I'm like, well, yeah, the disease is diffuse, but usually their disease is diffuse above and beyond the macula, is familial drusen or inherited drusen or dominant
Yeah,
drusen.
and, you know, already just in that history, you know, and one thing I hate is, and Mo, I'm sure people do this to you, you know, they'll come up to you after the lecture and they'll just show you an OCT and say, what's this OCT, right? And
Yeah.
you never make a diagnosis without the full story. So that patient, when you just tell me the story, right? 30 years old, African-American, told they have AMD. Those are kind of two things, 30 and African-American, very unlikely to have macular degeneration, right? So once you start to hear the story and you get the demographics, it doesn't sit right. So it makes you think this is probably not true macular degeneration.
Right. So, and that's very important. And I get that as text and emails. Somebody sends me one scan of something that's even missed, and it's like, what is this?
Yeah.
Well, I don't know. Tell me about this patient. You know, you got the
I mean,
whole.
I love OCT, but you
Right.
can't use OCT in a vacuum.
Right.
And there is a danger too from just using one slice. You know, you really have to look all through the macula. This is a great picture in my mind of dominant drusen that you have
Yeah.
here. And you know, one thing that I learned, and I don't know if it's 100% true or not, but someone once told me that, you know, anytime you see drusen that goes on the other side of the optic nerve, right?
Right.
That
Nasal.
when it goes nasal to the optic nerve, that's almost always dominant drusen and not macular degeneration. So anytime you see that,
And there is one other thing in this picture too, and I think we have to stop for questions or what have you. But there is also a condition called peripheral drusen that's very common.
Yeah.
And peripheral drusen has genotypic similarities. And when you do OCT of the peripheral, you know, retina of these patients with, you know, peripheral drusen, it looks just like macular drusen in AMD patients. So these patients don't have AMD, but they have risk of AMD. And any one of these patients, a patient with familial drusen could also go on develop AMD down the road. So it doesn't preclude them. So, but to make that diagnosis at 30 years of age, to tell somebody you have, you know, macular degeneration is a disservice to that patient and the patient's family members or what have you. So that's, you know, these are the reasons. And we didn't get through all these cases. You know, time flies, you know, especially when Steve and I talk, you know.
Mo, there are a couple of questions. Maybe
Okay.
we just get to these couple of questions just to you know,
Sure.
have some conclusion. So one is, are there any studies that have confirmed nicotine consumption through means other than smoking increase the risk of macular degeneration? You know, all the studies I've seen, you know, specifically look at cigarette smoking. I've read one or two that looked at pipe or cigar smoking, but most of them look at cigarette. I'm not familiar with any particular studies.
There are a couple of things, there are a couple of papers out on vaping actually.
Oh yeah?
Yeah. On vaping, they're showing some, you know, sign of that. But, you know, it's chemistry basically. You know, this damage comes from nicotine and nicotinic acid. So no matter how you introduce it to the body, you know, so if people want to make that an excuse to do other than smoking, you know, so be it. But
yeah, right. Another question, any evidence that antioxidants will help reduce changes ahead of vision loss as only as ARED showed helpful from the 1 out of 4 converting from moderate to severe? Yeah, I mean, based on, you know, the AREDs and AREDS 2 study, we only know that those patients with moderate, you know, to intermediate disease, that the vitamin is really helpful. That doesn't mean that I don't sometimes prescribe them a little bit earlier, but the science isn't 100% clear. And they're probably, to know if taking them before you have AMD is protective is never going to be done because it's just too long.
No, and it takes too long. But I think you and I have the same belief that if you're worried about it, the carotenoids, non-zinc formulations are better in younger patients than putting people on that heavy dose of zinc out for a number of years, you know. So I don't think there is any danger of using carotenoids, you know, lutein, zeaxanthin, mesozeaxanthin.
No, I agree.
Even with a lower degree of zinc or what have you, but I wouldn't go heavy duty on zinc.
One of the speakers thought about John Nolan's finding in the commercial vitamins for AMD do not contain the amounts listed of antioxidants. You know, I think if you stay, my thing is always stay with a good brand, right? Stay with a name brand. You're less likely to get that kind of stuff messing around. Yeah, and do you have a slide? Someone's asked about adult vitiliform. Do you have a slide on adult vitiliform you can share with us real quick? I thought you did, but I might have been wrong. And then someone said, did you say MACT is always temporal to the macula, or most
So
commonly? Okay.
early on it starts, but as the disease progresses, it could translate to the whole foveal area. But yeah, usually you look more for the changes in the temporal to fovea. Now, adult vitelliform is just like MacTel. It could be like sometimes you see so vitelliform means egg yolk like,
Yeah.
So a vitelliform lesion in Latin means an egg yolk. So you don't always see the egg yolk. If you remember in Best disease, we used to have egg yolk and scrambled egg. So this vitelliform material, which is also like lipofuscin type material, it can get metabolized over time, like things like this. And as it gets metabolized, the look of the fovea changes, and actually patients can lose vision. The fovea looks better, but just like I said, unless somebody's got adult vitelliform and AMD, the disease is very localized to the foveal area. And they do have risk of, lot less than AMD, but they do have risk of developing choroidal neovascular membrane. So these are a couple of pictures. And this is a multifocal adult vitelliform, so you could have more than one vitelliform lesion, so this is a true vitelliform, it's egg yolk. Whereas in these areas, it's been scrambled up and it's been sort of metabolized. So the look is more like a geographic atrophy. So, and the other thing we have to realize in this dystrophic diseases, there is a lot of overlap. This whole group of what we call pattern dystrophies, they have, again, genotypic similarities, phenotypic similarities. To me, many of these diseases are lot less aggressive than actual AMD is. AMD is a fairly aggressive disease, So not everybody loses vision, but it could, they're all at risk.
Yeah, I think you bring a good point. And our old friend Leo Sims, when I say old, I meant I've known him for a while, not that he's old, just to clarify. But he has either of you seen the variant that involves a macula like Leventis or Sorsby degeneration? I think that I have. In order to know for a fact whether or not it's some of those, you actually have to do specific genetic testing looking for specific variants. So I've seen ones that I think are that, but I've never actually had one that I've actually had genetic testing that proved it.
So I asked the retina specialist friend of mine one year, I was looking at the patient, I said, this patient probably has Sorbs. This is years ago. Have you ever seen a Sorbs? He said, well, if I look at the macula and I don't know what it is, I call it Sorbs.
No one's going to argue.
Nobody's going to argue.
Yeah, that's great.
But Leo asked this question. Leo, I actually have a picture of a patient with Sorbs. I emailed it to you.
Yeah. Let's see. Any other quick questions we can answer here? You mentioned drusenoid PEDs are indicative of AMD progression. So in the presence of PEDs itself indicative of AMD when there are no accompanying drusen.
No, you can have idiopathic PEDs.
Yeah.
In fact, idiopathic PEDs are usually not filled with that hyper-reflective material. They're more empty and they linger longer without going away,
Yeah. Let's just see if we can get these last two questions and then maybe we'll call it a night. Which was the disease that showed in the nasal macula? That was a patient that had the preeclampsia, right?
Right. So that was a random thing, so that doesn't always happen to nasal. But I was making a distinction that same type of change can happen in MacDel patients. So in MacDel is going to be temporal to fovea. So
that's a good point.
Right.
And then if you see a single small drusen in one eye in OCT, would it be considered too early to classify it as AMD?
No,
I don't think so. And, sometimes we get like really nervous. Like you don't want to tell someone they have AMD, but the sooner you know you have AMD, then the more likely the patient might start to eat healthy, might stop smoking, might lose weight, might start to do those lifestyle changes that make a difference moving forward. So I think telling someone earlier rather than later, you're actually doing the patient a favor.
So if you see a single drusen, right, Steve,
Yeah.
drusen, do a radial scan of the macular area, look at and do an EDI, because when you want to look at the RPE and the choroid, you want to have depth enhanced, imaging, not because you're not looking for epimacular membrane or vitreomacular. Look at how robust the RPE is, how robust the choroid is, and you got a single drusen. We all develop drusen on daily basis. That's pardon me saying that, we all poop. Our photoreceptors poop. If your RP is healthy, it recycles that junk. If your RP is not healthy, it cannot keep up. Even in AMD patients, drusen goes away. It over time gets metabolized. That study they did for sub-threshold laser to see if they can get rid of drusen. Yeah, they got rid of drusen, but they couldn't get rid of AMD. That's why they stopped that study years ago, So just because somebody has 1 or 2 or 3 drusen doesn't mean. That goes to my expression, if my uncle has a mustache, not everybody with mustache is my uncle. Stuart, do you get that? Steve doesn't.
I like that. Listen, that's been a great presentation, and we have a really special treat tonight. We're going to close with Dr. Ferrucci playing Mozart's Requiem in D minor. So go ahead to the piano as we close up tonight's event.
Yeah, that's not going to happen, Stuart. I can't play a lick on that thing, but it looks nice, doesn't it?
I thought that's what the piano behind you was for. I'm sorry. I thought we were going to close with that tonight. Well, listen, thank you both. Thank you to the audience for the great questions, the participation. Thank you for tonight's sponsors, and most especially, thank you to the Macular Degeneration Association. These series of events have been very informative and I think brought a lot of light to the disease. And so with that, we'll close tonight's program. Remember, we will post this hour to everyone's OE tracker number electronically to the COPE site on your behalf. Thank you all. Thank you, gentlemen.
Thank you.
Thanks, Mo.
Thank you.